everyone. Welcome to Being Patient Brain Talks. I'm Deborah Kan, founder of Being Patient. Today, we're going to talk about a topic that many of you have written to me about, and that is seizures and dementia. It's not uncommon for people who have been diagnosed with dementia to suddenly get a seizure when they had no medical record of seizures in the past. So we thought we'd delve a little bit deeper into this topic. Joining us is Dr. Dona Murphey. She's a neurologist and a neuroscientist who is an expert on this topic. So Dona, thanks so much for joining us and great to see you.
Thanks so much for having me. It's great to see you as well.
Okay, it's a little bit like a chicken and egg scenario, right? It's like, are seizures a symptom of dementia, or do seizures cause dementia? What do we know exactly?
Yeah, so we think that seizures or epilepsy, which is a disorder of seizures, can actually herald, complicate, or be driven by what is happening in dementia, specifically with respect to Alzheimer's dementia. That's where we have the greatest evidence for this. Late onset epilepsy, which is seizure disorder that develops as we age, rises in parallel with increased incidence of Alzheimer's disease. And we see actually this bidirectional relationship between epilepsy and dementia, such that when you have epilepsy, actually, like younger, like it may have been diagnosed, when you were a child or in middle age, or a little later in life, but without any cognitive symptoms at that time of diagnosis, that actually puts you at 2 times the risk for dementia. And the reciprocal is also true. If you have dementia, as that dementia progresses, you also have an increased risk, about double the risk of having epilepsy concomitantly.
Okay, I have to ask you a really basic question. If you have a seizure, are you defined as an epileptic, or what actually defines epilepsy? Is it just, can a one-off seizure be epilepsy?
Yeah, we typically think of it as an unprovoked seizure, but it really depends also on some other circumstances. We usually, in a person who presents with kind of a clinical history that is consistent with a potential seizure, we're going to do, some diagnostic workup on them that often will include imaging of the brain, like an MRI of the brain, and then also an EEG, which is trying to measure the function of the brain in terms of the electrical activity, which is how we, diagnose seizures specifically. If the person has some underlying structural abnormality in the brain and they have their first seizure ever, that is consistent with like where that abnormality is in the brain, we may call that epilepsy even without ever having had a second event. However, if somebody comes in and there is like a good clinical history for something like alcohol withdrawal, or, they just had trauma to the head, which can provoke a seizure, that we will not call epilepsy. If there's no abnormality on brain imaging, there's nothing to suggest this person has an underlying propensity to have seizure disorder. We kind of say that in some or many cases, we kind of allow people to have a seizure in a lifetime, and we don't call that epilepsy necessarily. Yeah.
Okay, people have written to us at Being Patient, and they've actually described this kind of staring into space, right? Like this kind of like, you're not there, but you appear there, but you're not responsive. One person wrote to us and said that was actually later diagnosed as a seizure. So I guess my question is, do seizures that are caused by dementia, Alzheimer's, look differently than they do otherwise?
Yeah, so the literature, like the scientific literature, suggests that about 30 to 80%, depending on the study, of the seizures that we see in people who have a diagnosis of dementia, they are of this kind of this type where your awareness is kind of impaired. They are typically focal in that they come from one area of the brain. And the way they present clinically is what you're describing. So the person will be in the middle of doing some task, maybe they're talking to you, and suddenly they'll kind of stop. They may have like a blank stare on their face. They're briefly unresponsive for maybe a period of about 1 to 2 minutes typically. So it's pretty short. And they may have some like behaviors that are kind of stereotyped behavior. So if you see this more than once, you'll notice that they may have some lip smacking, some chewing behavior, some picking behavior with their fingers. And yeah, you might not notice this because, especially as the dementia advances, because of their cognitive changes, it might not be very distinct from how they are just ordinarily. But, earlier on in the illness where you can also see these kinds of events, that might be pretty different from how they are behaving ordinarily. So it is something to look out for, to definitely mention to your loved one's doctor if you see that kind of behavior, and to ask about it if they don't tell you about it. And most people who are diagnosing dementia are not having these conversations about these kinds of events. And it is, I think, I don't know, it makes it more challenging than it should be for us because it accelerates the cognitive decline with dementia to have this happening at the same time. So
Yeah,
it's
I
good
mean,
to identify.
it,
Yeah.
it's really interesting talking to you because as you speak about this, I'm thinking to myself, oh, I've seen my mom that way. Was that a seizure? So that's the hard part. And what I wanted to ask is, you mentioned specifically one part of the brain. Which part were you talking about, and how does it impact that part of the brain?
Yeah, so it is the kind of like middle of the brain, in something called the temporal lobe. So kind of middle and underneath part of the brain, that for whatever reason gets kind of preferentially involved in the kinds of seizures that we're seeing more often that are associated with dementia. Um, yeah, and we think that this is related to the fact that you have, if we're thinking about kind of the protein deposition like hypothesis in dementia, you do have dementia, those proteins depositing in these areas of the brain. So we're talking about amyloid and tau, right? And so what we see in like animal models is this kind of hyperexcitability that happens like in the hippocampus, which is like the memory forming part of the brain in that mesial temporal lobe, or that kind of inner underbelly of the brain. And that hyperexcitability prevents us actually from having normal memory consolidation in sleep, especially. I think that's impacted there. And then it goes on to affect potentially other parts of the brain. When you have a focal seizure, if your brain kind of takes care of it, it doesn't go anywhere from there. But if it doesn't, it's kind of like putting a fire out, right? Like if it doesn't take care of that issue, it can spread from that area to involve other areas, and potentially the entire brain, which is the most dangerous circumstance because that can compromise your breathing, your heart rate, things like that. Yeah.
Do these type of seizures, do they ever present as, what we typically associate seizures as being, which is convulsing?
Yeah, they can for sure. More often, I think they're this type that is kind of focally restricted, and they're transient. They happen in 1 or 2 minutes. But this is also a reason why I think it's important for people to know that this might be happening, because it's a reason potentially to treat that. If it spreads, that can have catastrophic consequences, as I mentioned, if it stops your heart. Right. And this we call sudden unexpected death in epilepsy. And we do see that in epilepsy that is not well treated, well controlled. And of course, if you haven't even diagnosed it, to have the person on any kind of treatment, then, they may be having these events pretty frequently. You don't know. So from that perspective, it is a reason to consider treatment for those events. But I often, am talking to, I work with a lot of caregivers, and so I wear many hats in the paid labor that I do. One is with an EEG diagnostics company, and it's like work around a lot of like epilepsy drug development, dementia drug development. And then the other is with caregivers of people living with dementia. And when we have these conversations with caregivers, I think it's important for them to recognize that, yes, while you can have some catastrophic consequences from having seizures that are uncontrolled, and it can lead to accelerated cognitive decline, which is not helpful either, right, in dementia. The flip side of that is you put them on an anti-seizure medication, and actually the side effects of that medication can be cognitive, right? They can make somebody dizzy and like more susceptible to falls, right? So like it is really kind of a balancing act, and it's should really involve shared decision making between the families and the care provider, the clinician.
What can you see in an EEG? Like, is it something that you could use to determine if someone's at risk, or is it something to determine whether or not a person has had seizures before?
It can be a bit of both. So if somebody comes to you with a clinical history that is very suspicious for a seizure, and this kind of seizure in particular, right, with this kind of description that, oh yeah, once in a while they're doing something and then they just kind of blank out for like a minute. Then, somebody with an existing diagnosis of dementia, you want to have like a high level of suspicion for that kind of clinical history. And you really should be ordering an EEG at that point if you didn't already have that for that patient. And even if you had it, like if it was a short study and it did not capture sleep, especially, it's very possible that you did not capture an abnormality in that study that's epileptiform. But if you capture sleep and those sleep-wake transitions that are kind of more vulnerable to these kinds of abnormal discharges and seizures as well, like silent seizures, then you can be more confident that, like, if you had a longer study that captures sleep and it didn't show any abnormality, that you're probably going to be okay. The longer the study is, the more likely it is that you'll capture an abnormality. So that's something to consider as well. Like a 2-hour study versus an overnight study are different in terms of their ability to capture something abnormal. But yeah, so I think EEGs will capture epileptiform activity. Sometimes that activity is not correlated with any seizures. So there might be other reasons. Like we have a lot of, I'll say, for the work that I do on the EEG diagnostic side, we have a lot of studies that are ordered for the reason of memory loss or cognitive decline. And about half our studies actually are ordered for that reason. That does not mean the person has dementia. It may actually mean that they have just epilepsy, in fact, right? Epilepsy alone can, especially if you have uncontrolled seizures, that can cause cognitive decline. But yeah, looking for those abnormal discharges, because those do seem to correlate with cognitive decline, and certainly seizures, like frank seizures, do correlate with cognitive decline. I think it's useful to have an EEG for people who have dementia, especially if they're reporting that kind of clinical history, then it's clinically indicated, really.
Yeah, it's really interesting because I was actually speaking to someone who works in a clinical trial center and said that, most of the patients coming in with Alzheimer's have had seizures, right? And so I guess my question is to caregivers, I mean, that stare, that kind of blanking out, which could be classified as a seizure, might not necessarily be defined as a seizure when you're watching your loved one go through it. I mean, clearly, I would never have thought my mom was having a seizure. I don't know if it was a seizure, but when you describe that, I could say, oh, maybe that was, right? So, how do people prepare for this? I mean, it is like we talked about. You said it could be both. It could be a symptom. It could be a cause, because we know, it elevates the risk of dementia. But if you have a loved one with dementia, or what do you look out for? How do you even, most people aren't participating in sleep studies, especially if they have a diagnosis, right? So what do you do?
Yeah, that's a really great question also. I mean, I think it is, that we have to educate all family members. I mean, also, honestly, at the beginning of this disease, I think people who have the disease themselves may be able to recognize that they're, quote, losing time. That's how, like, this is kind of classically characterized by people who experience it themselves. Like they're in the middle of doing something and then they don't know like what happened, and then they're back. So that, like, patients themselves need to be educated about that. And then families also, obviously, if they're observing their loved ones behaving in this way, then they need to have like a high level of suspicion. I mean, if you make the decision ultimately, or for whatever reason, if the, diagnostics are not available to you, if those specialists are not available to you, if there's some time in waiting for that, what we say, like, once we see you, is probably what you want to put in place in terms of precautions even before you get seen, which is that if you see that kind of behavior, and you're probably already doing this for somebody who has a diagnosis of dementia, but just as a reminder, you don't want them to be, engaged in activities where if they lost consciousness or had altered consciousness for a short period of time, they'd be in danger, or they'd put other people in danger. So, people have set their house is on fire, right? Because they're in the middle of cooking and they have one of these kinds of episodes. You can drown if you are swimming or if you're even bathing and you're not supervised, right? Like, no, people are not aware that you're doing that and just kind of keeping an eye on you. Operating heavy machinery, like these driving, like these things can all be very dangerous. But all of these activities, I think, probably, if we're doing the right thing in terms of prevention in dementia, or prevention of harm in dementia, rather, we're probably already monitoring those activities or limiting those activities. But it's good to think about again for seizures as well.
How much do we know about the interaction between seizures causing dementia? Like, what do we know about that, and how much is the elevated risk?
Yeah, so I mean, this again is two different things. One is the seizures themselves, which are like a more prolonged, like technically speaking, it is at least 10 seconds of evolving electrically abnormal activity in the brain. Seizures themselves, which can be clinically apparent, or they might not be. They might be like totally not apparent to the person themselves or to the family members around them. Or this thing that they call subclinical electrical abnormal electrical activity, right? Or epileptiform activity. So that in either case, we're seeing a correlation between those things and cognitive decline. So it's really important that people are aware that either of those things can actually increase the risk. And as I mentioned before, it is about 2 to 3 times the risk, right? When you have those kinds of abnormalities. Well, I should say specifically that was for late onset epilepsy, but you do have increased risk with this subclinical epileptiform activity and with seizures in general. Yeah.
Do we know what the relationship is between maybe plaque in the brain, and like, is there any way to say, oh, you have this pathology, like you have plaque, or you have tangles, therefore, you're at a higher risk? Or do we not know when that kind of intersection between risk of seizures and dementia comes?
Yeah, I mean, it's interesting because there is like animal evidence and then also clinical evidence that you can see a subclinical epileptiform activity well before, like years before you actually develop dementia, which is part of the evidence that suggests that maybe it plays like a role in causing dementia, right? But you also see increased epilepsy with dementia progressing. So really all along the course of the disease, I think it's really important for families to be educated, patients to be educated about the increased likelihood they have of this other disorder, that whether it's causing the dementia, it's making the dementia worse, it's probably worth considering treating that condition because it is treatable, right? So it's unfortunately not the same kinds of outcomes as for epilepsy in general. The epilepsy that is associated with dementia, it has about a 25% responsiveness to medications, as opposed to epilepsy without dementia, that you might have had from early life. That has about a 65% response to medications. So it's not as, the outcomes are not as great, but 25% response is still worthwhile if that means you're going to slow down the progression of the disease, right?
So
Or
are those the anti-seizure medications? Like, what medications are you specifically referring to?
the one that appears to, there are lots of anti-seizure medications. The one that appears to be the best for epilepsy associated with dementia is levetiracetam or Keppra. That medication, unfortunately, when I talk about like the balance that you have to strike between side effects and the desired effects of the medication, is that levetiracetam is well known to produce behavioral problems, disturbances, and sometimes that's already an issue with our loved ones with dementia.
Like
So
outbursts, like what type of like
yeah,
inappropriate
anger, yeah,
anger?
anger,
Yeah.
agitation, yeah. And so we have to be careful with that, right? So like, somebody who already has that as like a major feature of their dementia. And I have to say here too, like being someone who supports family caregivers of people living with this condition, I will say a lot of the time those behaviors are because we don't know how to communicate and how to manage, and not necessarily because they intrinsically have a problem with their behaviors. That being said, if the overall environment and that person themselves, that there are behavioral issues, right? In that context. you might not want to start with levetiracetam. You might want to start with a different agent. And because this is usually a focal kind of seizure, if we see that also, shown in the EEG, then we want to start with medications often, or we can start with rather the ones that are more focal, targeted to a focal epilepsy, because there are different classes of medications for generalized epilepsies and more focal epilepsies. So you could start with an agent like that is maybe not Keppra. Keppra is actually a general one. It's for generalized. It has it's broad spectrum, as they say. But yeah, you might start with something that doesn't have that kind of side effect profile if that's of concern.
I just want to make sure people are super clear on this, because this part is a little bit confusing to me. Not knowing whether or not my mom had a seizure or not, but recognizing that one of those symptoms could have been a seizure. What do we tell our neurologists, and how, like, you go and see them, you get an appointment? I'm pretty sure not a lot of them are going to run EEGs, right? I might be wrong, but I'm just thinking that's probably out of the wheelhouse of offerings. So what do you do? I mean, I understand, like, your research and why it's so important, but to the average person, what do we do?
Yeah, so I think again, a lot of what we do with our caregivers in terms of supporting them is kind of equipping them with the language to be able to advocate best for their loved ones or with their loved ones. And here, I think it's important then for caregivers or patients early on in the disease, where they can still do their own advocacy effectively, right? To know how to speak the doctor's language a little bit, because unfortunately, yeah, it's going to be harder if you're not framing this in a way that they will interpret readily. So to say, my loved one has these events that last like 1 to 2 minutes, and they like blank out, and to describe it in the way that I've described these events are like that's how we characterize them, like as epileptologists or neurologists, and to speak that language, right? They're picking at things, they're like their mouths are moving. I'm worried that this is potentially a seizure. I know that, with dementia, people have increased risk of that. What do you think? Do you think it might be reasonable to do a study, an EEG study, or to empirically treat, right? To treat to just try with a medication, that's a possibility, especially if the studies are hard to come by where you are. This is still a clinical diagnosis, even though the gold standard for diagnosing epilepsy is an EEG. It's a
What
clinical
does
diagnosis.
that entail, going through an EEG? Is that like an hour? Is that 10 minutes?
Yeah.
What is it
And this is
exactly?
also another reason why it might not happen, right? Because if you have somebody with dementia who's really difficult, to manage in unfamiliar circumstances, this requires your head be kind of scrubbed down a little bit in multiple parts, and these electrodes stuck on, and for a period of 30 minutes to an hour mostly. But if they're trying to capture sleep, which, like I said, can be a lot more informative, maybe longer, it might not be very well tolerated by the person with the condition. So that's something to consider also in like the workup, and whether you want to treat empirically, for instance.
Yeah, I'm just picturing putting those on my mom's head, and I know exactly what would happen.
Exactly.
It's very difficult. So tell me a little bit about where the research is heading. Like, you did a great job informing us of kind of what we do know. What more do we need to know in order to really get more better treatment and better recognition about epilepsy and dementia?
Yeah, I think as far as the research, what is really exciting is like some of the EEG studies that we're doing that are quantitatively analyzing the activity in the brain of people who have dementia. So what we've seen is that if people can envision this, right, like what we're measuring in the brain is electrical activity. We look at that in terms of like the waves of the brain, right? And those waves have a certain frequency, and they have actually composite frequencies, different frequencies that are contained within your brain while you're sleeping, while you're awake, while you're engaged or not, in activities. And those things, when we measure them, they are distinct distributions of those frequencies between people who have dementia, Alzheimer's dementia, and people who don't. Now, there is no difference between people who have dementia and this epileptiform activity. versus people who have dementia and who don't have the epileptiform activity, those background frequencies are actually indistinguishable between those two populations. But between people who have dementia and people who don't, they're distinguishable, right? So
Could that be a way to recognize who actually pre-symptomatically? Could that be?
Potentially. So, we're thinking all about blood biomarkers or, other kinds of minimally invasive or non-invasive testing. Absolutely. People are working on that, but it's complicated. And so we don't.
I'm thinking about our E4 population, right? If you know that you have a genetic component to it, would it be worth it to monitor EEGs
Right.
just to understand risk value there? I mean, the E4s seem to be kind of the obvious population of to delve into the research to really understand what's happening even at a pre-symptomatic stage.
Yeah, absolutely. And I think, the drug companies who are developing drugs for dementia, I think it would really behoove them to look at incorporating EEG early on to see, can they actually stratify patients? Can they characterize them in a way that allows them then to say, how does my drug work on these subpopulations of people that had these kinds of EEG abnormalities or not, right? Whether they are frank, subclinical epileptiform activity or seizures, or there are these differences in kind of the quantitative analyses, the frequencies in those brainwave studies. I think that would be so amazing to do. And people are working on it, but it hasn't been adopted broadly. So yeah, I think there is definitely more work to be done. The other exciting kind of horizon is as we think beyond amyloid pathology, right? About abnormal neuroinflammation, abnormal electrical activity in the brain, right? I think that we're going to have a much richer idea of the various things that are happening and the various points of intervention. Yeah.
It makes me think about the athletes. Has any of this been applied to athletes who have multiple concussions? I mean, that kind of seems like a population who could answer some of these questions.
That too. Yeah. I mean, all of the people who have modifiable risk factors, who we know with those modifiable risk factors, if they're not well controlled, they go on to have higher risk of developing dementia. We could study their EEG, all of their EEGs, right? But yeah, certainly TBI is another population.
Donna, thank you so much. Super interesting research. We know firsthand this is a topic that does impact a lot of people. I'm sure a lot of people are going to watch this and say, oh, that makes a lot of sense to me. So I think patient awareness and caregiver awareness is critical to really kind of getting to the bottom of the interaction between seizures and dementia. So thank you so much for your time and sharing your knowledge.
Of course. Thank you.
So if you missed any of this interview, don't forget to go to beingpatient.com. We're going to post this whole interview on our YouTube channel and on our website. Also, don't forget to sign up for our newsletter. That's where we tell you about talks like these. And feel free to ping me anytime, Deborah at beingpatient.com. I want to hear what you want to hear about. So thanks everyone for watching, and we'll see you next time.